Hello, welcome to the Pediatric Brain Tumor Foundation's webinar, Addressing the Cognitive Impact of Childhood Brain Tumors. My name is Kathy Riley. I'm Vice President of Family Support for the Pediatric Brain Tumor Foundation and also the mother of Peter, a long-term survivor of a pediatric brain tumor. We are honored to have you joining us today for this important webinar. The PBTF provides programs and resources to support families facing a pediatric brain tumor diagnosis throughout their journeys. We'll provide links to some of those programs and resources at the end of today's webinar. Before I introduce our presenter, I have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the presentation. Please type your questions into the Q&A feature found at the bottom of the Zoom window. We'll not get to every question today, but we'll try to get to as many of your questions as possible. Dr. Heather Conklin is a full-time faculty member in the Department of Psychology at St. Jude Children's Research Hospital, where she is chief of the section of neuropsychology. She earned a bachelor's degree in biology and psychology from Duke University before earning a doctoral degree in psychology from the University of Minnesota. She completed an internship and postdoctoral fellowship in neuropsychology at the Kennedy Krieger Institute Johns Hopkins Medical Center. Dr. Conklin's research program is focused on improving cognitive outcomes following treatment for childhood cancer. Primary research aims include using cognitive outcomes to inform modifications in cancer-directed treatment, improving specification of cognitive deficits following treatment, and developing empirically valid interventions that mitigate cognitive late effects. She has over 80 peer-reviewed publications and has received extramural funding from the International Neuropsychological Society, American Cancer Society, and National Cancer Institute for this line of investigation. It gives me the greatest pleasure to introduce Dr. Heather Conklin to come and share with us today. Dr. Conklin, welcome to the webinar, and thank you for being here today.
Thank you so much. Just going to take a second to get my slides going. Okay, it looks like we're all set. Can Kathy or Heather just confirm you can hear me and see my first slide?
Yes, we can hear you and we see your first slide.
Excellent. So thank you everyone for taking time today to participate in this webinar. I just want to say up front that this is a cause that's near and dear to my heart. I've dedicated my career to helping survivors and their caregivers, both in my clinical work and my research, and I genuinely hope that this information is helpful to you all, and I look forward to, after this talk, having time to answer your questions and have some discussion. So thank you again. So today I will be talking about, one mild issue. Okay. So today I will be talking about cognitive problems that childhood brain tumor survivors may experience and the latest approach to their management. I'd like to begin with this schematic as a talk overview. First, I will define the problem of cognitive late effects and the benefits of neuropsychological assessment to assist in tailoring interventions. Then I will talk about three main categories of research-supported interventions, which include pharmacologic or medication, therapist-delivered cognitive remediation, and computerized training. Finally, I will spend a little time talking about recent findings in the literature to suggest that physical exercise might offer cognitive protection or benefit. So childhood brain tumor survivors are at risk for cognitive problems, such as issues with thinking, attention, or memory. And these problems can relate to the presence of a growing tumor, or the problems can relate to treatment procedures such as surgery, chemotherapy, or radiation therapy. The time course of these problems can vary. Some problems may lessen or disappear during treatment, whereas others can emerge after treatment. Cognitive problems can reflect the location of the tumor, such as word finding problems and right-sided weaknesses in a child with a left frontal tumor, or they can reflect a more global process, such as hydrocephalus, which is obstruction of cerebral spinal fluid that can occur when the brain tumor is growing. And those problems can be associated with global cognitive issues like problems with attention or processing speed. Cognitive late effects are defined as problems that emerge 2 to 5 years after completion of treatment with certain chemotherapy medications and/or radiation therapy. And they've been shown to relate to brain-based changes such as decreased white matter or myelin. And this is the material within the brain that really supports efficient brain communication. Cognitive problems can also be secondary to sensory changes related to a brain tumor, such as loss of vision or hearing. And while research is being conducted to reduce treatment-related cognitive problems for some survivors may remain as an undesired cost that's associated with aggressive treatment required for cure. These cognitive problems can cause academic struggles and social problems, but most survivors can achieve a good quality of life with intervention, support services, and sometimes adjustment of goals. Cognitive late effects are relatively common among childhood brain tumor survivors, but the risk varies, with greater risk associated with a younger age of treatment, which is typically defined as less than 5 years of age, female gender, and higher treatment intensity, such as a higher radiation therapy dose or a larger region of the brain that is irradiated, and complicating medical factors, such as experiencing posterior fossa syndrome, meningitis, or a stroke during treatment. Importantly, research shows that children continue to learn following their treatment, but sometimes it's at a slower pace than same-age peers who have not experienced a brain tumor. And with a slower pace of learning, the gap in cognitive skills between survivors and their peers can grow larger over time. Greater specification of cognitive impairments among childhood cancer survivors is needed to improve our understanding of their cause, as well as to develop targeted interventions. Recent findings suggest impairments can occur most often in 3 areas that include attention, which means staying focused or difficulty filtering out distractions and difficulty dividing attention between 2 tasks, working memory, which can be seen as difficulty actively manipulating information in your mind. So for example, to be able to follow multiple step commands or to complete a task such as mental math calculations without writing them down. And processing speed, which is the ability to quickly take in and make sense of information. If you or your child is experiencing cognitive late effects, a neuropsychological assessment is highly recommended. Neuropsychologists are trained to assess thinking skills such as attention, memory, and problem solving, and they use this information so that they can determine individual cognitive strengths and weaknesses for a particular child. And then they use this information to develop recommendations that are tailored to that individual that might include some of the interventions I will review. A neuropsychologist can also provide education about how to secure academic services and supports within the school setting. Here's a list of some of the most common school services and accommodations that we advocate for based on an individual's needs. For example, in a child who's having attention problems, we may recommend seating preference, such as being at the front of the class or near the teacher, being away from distractions such as a window or a door or a student who's more distracting. A cueing system, for example, having the teacher use a specific secret cues, such as tapping on the desk to make sure the student refocuses on an assignment without drawing the attention of all the other students in the classroom, or a behavioral reward system, such as a check mark for every 10 minutes that the child is on task, and then based on the number of check marks in an hour or throughout a day, earning some simple rewards, which could be something simple at home, like some extra screen time or picking dinner that the family has one night of the week, or simple rewards in the classroom, such as being able to hand out papers or something else that's motivating for the particular child. For processing speeds, if you look down further in the chart, some examples of regular accommodations are to have extended time for assignments, exams, including statewide exams and college entrance exams, modifying assignments. So for example, having the student do just every other problem of an assignment to save time, and to have the teacher learn to give the student time to process instructions and to respond without rushing them, knowing that processing speed can be a particular challenge. So this table comes from an upcoming special issue that will be in the Journal of Clinical Oncology that is entirely focused on neurocognitive outcomes in survivors of pediatric cancer. So I hope everyone looks forward to seeing that in the spring, but this is a sneak preview of some items in that article. So two common ways to gain school services include an IEP, which stands for an Individualized Education Program, and or a Section 504 plan. Both of these approaches require parental consent, are at no cost to parents, and are developed specifically for an individual student. An IEP is based on education law, specifically the Individuals with Disabilities Education Act, and it provides specialized instruction or curriculum and focuses on what a student is learning. To be granted an IEP, the student needs to qualify under at least one of 13 eligibility categories. For brain tumor survivors, it is often easy to make the case for one of these categories, which is other health impairment, or OHI. For IEPs, the states do receive additional funding for all eligible students to assist with placing these accommodations and services in place. A 504 plan is based on a civil rights law, specifically the 1973 Rehabilitation Act, that provides for accommodations and modifications. Those are keywords you'll hear, and focuses on how the student is learning rather than what they are learning. To be granted a 504 plan, the student can have any disability that limits access to the school setting, and states do not receive additional funding for eligible students. With improved survival rates among children diagnosed with brain tumors, there's really been a heightened focus on optimizing quality of life for our survivors. Chief among these efforts have been developing cancer treatments that reduce cognitive risk. For example, using risk-adapted approaches that save the most cognitively impacting treatment for those children with the most aggressive disease. Further, sometimes surgery or chemotherapy is used to delay radiation therapy to reduce risk in the youngest children. More recently, radiation therapy approaches are also improving to include methods that spare greater amounts of healthy brain tumors surrounding tumors, such as using conformal approaches or proton beam therapy. I'd like to turn now to talk about research support for different interventions that target cognitive late effects in our childhood cancer survivors. I will start with pharmacologic or medication-based interventions. The benefits of stimulant medications such as Ritalin or Adderall are well established for improving attention in otherwise healthy children who've been diagnosed with attention deficit hyperactivity disorder or ADHD. However, the response rate and the tolerance levels may differ for children who've been treated for brain tumors. And the evidence for the efficacy of stimulants such as Ritalin or methylphenidate for cancer survivors was mixed based on preliminary studies, but these studies also tended to be limited in design. For many years, I oversaw a multi-institution methylphenidate or Ritalin trial for cancer survivors that we called MEMPHIX. I will walk you through this busy flow chart. If I can get my mouse over to the screen. One sec. Okay, here we are. So first, we screened 469 children who were survivors of brain tumors or leukemia to identify those with significant attention problems and learning difficulties. We then went on to what we called an in-lab, which was an in-clinic trial where we specifically evaluated medication side effects. And then we followed that by a home crossover, which was a 3-week home-based trial where we evaluated both attention and social skills benefits using parent and teacher report. And finally, we had a year-long maintenance phase for individuals showing initial benefit to evaluate potential long-term benefit of this medication. So here we can see some of the results from the 3-week home crossover phase. We have responses from parents over here on the left and responses from teachers over here on the right. And what we can see is that both groups reported a significant improvement for 2 doses of methylphenidate. So low dose is indicated by the gray bars and moderate dose by the purple bars. And they indicated improvements specifically for symptoms of inattention and ADHD, that's for the parents here, inattention and ADHD, that's for the teachers over here. And teachers also reported a significant reduction in symptoms of hyperactivity for individuals receiving either dose of methylphenidate or Ritalin. Teachers also reported a significant improvement, up here, for social skills, but parents did not, if we look over here on the left. And we think that could relate to the fact that parents have very few opportunities to observe their child's social interactions with just 1 week of time that the study looked at, whereas teachers are consistently showing they're seeing their students with their peers. So we also looked at side effects, and this graph shows a higher number here, the number of symptoms endorsed, as well as severity of side effects when we compared the moderate dose, these gray bars, to the placebo, or the moderate dose to the low dose. But we did not see an increase in the number of symptoms when we compared the low dose to placebo, showing that that low dose was really not associated with a significant number of side effects. And when we look at this rate and severity of side effects, compared to what we see in otherwise healthy children with ADHD, it is very similar. And overall, our families found that this medication was generally tolerable for their child. In this slide, we can see that the teal lines are indicating those children over the year-long maintenance trial who were still taking the medication. And it showed that the benefits could be maintained throughout that year-long time period. There are other medications now that are being studied in childhood cancer survivors that include another stimulant medication called modafinil or Provigil that was developed specifically for sleep disturbances or narcolepsy. This medication has shown benefits for cancer-related fatigue, and there are trials underway to look at cognitive benefits for childhood cancer survivors. A newer drug of interest for cancer survivors comes from the dementia literature and is called donepezil or Aricept, and has been shown to offer attention and memory benefits for adult cancer survivors, as well as initial executive function and memory benefits in childhood survivors. We are currently also investigating agents such as memantine, and these medications are prescribed during cancer treatment to see if we can offer brain protection from cancer-directed treatments. So in summary, when we talk about pharmacologic or medication interventions, findings from our methylphenidate trials are encouraging and reveal an intervention that is beneficial and safe for many childhood cancer survivors with evidence for attention and social skills benefit. However, it should be noted that children were excluded from participation in the methylphenidate trials for medical contraindications. So for example, if they had poorly controlled seizures, they were not eligible for the methylphenidate trial. And 36% of parents refused participation, even if their child had attention problems, indicating concerns they had with placing their child on a stimulant medication. The response rate was encouraging, and about 45% of survivors showed nice benefits, but this is lower than the 70 to 80% benefits that we see in children with ADHD. So taken together, these findings really highlight the need to look at non-pharmacologic or non-medication interventions as well. So I'd like to turn now to talk about therapist-delivered cognitive remediation. So the most comprehensive approach to cognitive remediation for childhood cancer survivors is called the Cognitive Remediation Program, or CRP. And this intervention uses strategies from 3 areas, including brain injury rehabilitation, where, for example, the therapist provides repetitive exercises that target attention. Special education, where the therapist trains the student in metacognitive strategies such as task preparedness or task monitoring. And clinical psychology, where the therapist can use cognitive behavioral therapy approaches, such as reframing of cognitive struggles the student might be experiencing in more positive terms. For this program, participants complete 20 two-hour one-on-one sessions over 4 to 5 months. Bob Butler and Donna Copeland, who developed this program, completed a multi-center randomized control trial that included 161 survivors of childhood cancer, and St. Jude was a site in this study. We did screen all participants to identify those who were demonstrating attention problems, and we found that those participants in the CRP, or the Cognitive Remediation Program, experienced a significant improvement in academic skills, used more strategies in problem solving, and showed improvements on a parent-rated measure of attention. However, when we worked with them in the clinic on performance measures that we gave the child, we did not see improvements on measures of attention, working memory, or episodic memory. Another study was completed by Sunita Patel and her colleagues at the City of Hope. It included 12 childhood cancer survivors and had 5 components that are somewhat similar to the cognitive remediation program just reviewed. It included general problem solving, such as learning to state the problem and generate or weigh solutions, study skills, again, like task preparedness and monitoring, information processing, which were specific memory strategies, such as chunking information and using visual imagery, reviewing compensatory strategies, such as the SQ3R method of survey, question, read, recite, and review, and collaborative contacts, where they would teach parents and teachers the strategies and ask them to implement them in the child's daily environment. So all reported cognitive measures for this study showed some improvement, with writing samples and social skills showing the most improvement. When we look together at the evidence for therapist-delivered cognitive remediation, we can see that the findings from the few studies that have been conducted in this area offer initial encouragement, particularly with respect to improving academic skills. Also, parents and teachers really understand the techniques, and their involvement may offer the greatest effect by extending the intervention beyond that one-on-one therapist session. And further, there are no medical concerns or contraindications as we saw with stimulant medications. That said, these interventions do require a large amount of time for providers and family alike. The benefits tended to be modest, and there are relatively few centers throughout the country or the world that offer this type of intervention. So this really pointed to the need for less expensive, less time-intensive, and more portable cognitive intervention programs. So this brings us to discuss computerized training. So computerized training really refers to a group of computer software programs that are designed to exercise specified cognitive processes. Most require repetition of similar exercises over multiple sessions, and the difficulty of the task is graded and increases with demonstrated success. Many programs require some level of coaching by a trained professional who provides feedback and assists in maintaining motivation. CogMed is the most researched of these programs. It was developed, interestingly, by neuroscientists who work together with game developers to make it an engaging intervention. There are 3 age-based versions that span a very large age range from 4 up until the oldest of adults. And it consists of 30 to 45-minute sessions that are completed each weekday for 5 weeks. The child is guided through 8 rotating exercises daily that train both visual, spatial, and verbal working memory abilities. And importantly, as ability improves, the exercises become more difficult. Compliance and performance can be tracked remotely over the internet, and feedback is provided during weekly telephone coaching sessions to try and troubleshoot problems the student may be having and help maintain motivation. So pictured here is an example of a task from CogMed. This is called the asteroids task, where the child will see a different number of asteroids here in space that light up in a particular order, and then they're instructed to click the asteroids in the same order that they lit up, the trick being that they will be moving around in space during that time. So the task starts relatively easy with just 2 asteroids and can build up to anywhere beyond 10. Over here, we see that it tracks the child's level of performance and provides them with feedback. So in this case, the child is reliably performing well at having 3 asteroids, and we look to see this improve over time. So there's quite a bit of emerging research to support CogMed with different populations, and results from randomized controlled trials indicate that CogMed has demonstrated success for improving working memory and executive functions in children who've been diagnosed with ADHD, healthy children with working memory problems, and adult stroke survivors. There's also some evidence to suggest that benefits are maintained 6 months after training. Findings from 2 different neuroimaging experiments where healthy adults were in the MRI showed increased brain activity when you looked from before training to after training that related to improvement in their working memory performance. With these findings really suggestive of what we call cortical plasticity, which means that not only are we seeing cognitive changes, but we're seeing brain-based changes with this intervention. So here's a diagram for a CogMed study that we completed here at St. Jude with childhood cancer survivors. I can find my mouse. Here we are. And so I'm going to walk you through this. We screened 128 children who were survivors of brain tumor and leukemia who were at least 1 year out from completion of all their cancer-directed treatment. We had 80 or 63% who qualified with working memory problems. We randomized, similar to a coin flip, which group these children went into, with 34 randomized to receive the CogMed intervention and 34 that were in what we called a waitlist control group, which meant that they did not get the intervention during the study, but were offered it after the study was completed. We found that 30 or 88% of the children completed at least 20 of their 25 training sessions, which was needed to be considered compliant with the intervention. And the majority of these children returned, wrong way. Okay. The majority of these children returned for immediate and 6-month follow-ups, where we completed cognitive testing with them in our clinic. So here you can see just a number of the different tasks that we gave. I don't expect people to know what these tasks are. And here we're looking at how much the scores changed for those children who had CogMed and how much for the control group. And what we were able to see was that there were significant group differences showing that the group who had the intervention showed significantly greater improvements than the control group on measures of attention, working memory, and processing speed. These graphs just show what happens over time. Here, this shows us that the group that got the intervention showed those benefits and then maintained them for at least 6 months on both spatial measures of working memory as well as verbal measures of working memory. So when we look together at the evidence for computerized training, we can see that these programs can be administered remotely in the child's home, thus extending our reach to individuals who do not live near providers. The time burden is reduced relative to those interventions that require one-on-one time with the clinician, and the scheduling can be flexible around the child and family's schedule. And there are a few medical contraindications, perhaps photosensitive seizures being the one concern. That said, those that are available for clinical use are relatively expensive, and right now there is not insurance coverage for these interventions. Some individuals may lack the requisite technology, which was really limited in our experience. All you need is a computer or a tablet that's internet connected, and generalized ability to higher level skills, such as academic skills, is still being investigated. So the following is just a list of commercially available computerized cognitive training programs. I am not endorsing these beyond the research I've just reviewed. I provide this in case you are interested in investigating whether it's something of interest personally that fits with your available time and financial resources. There is a cost range, with Lumosity having fees based on time of use around $100 per year or less if you just do it per month. Excuse me, my light went off. Okay. And CogMed costing closer to $1,200 for the entire training that includes coaching and evaluations. So we're going to now just spend a little bit of time talking about exercise interventions. The medical benefits of physical exercise are well established, including decreased risk for cardiovascular, metabolic, and metastatic disease. And the cognitive and brain-based benefits are less appreciated, but with emerging research evidence to suggest that exercise is associated with improvements in learning and memory, with delayed age-related memory declines, with typical aging, or even with neurodegenerative diseases such as Alzheimer's, promotion of recovery following acquired brain injury. So individuals have better outcomes who have a traumatic brain injury or stroke if they exercise, and mood enhancement or antidepressant effects. Among those studies that have been conducted with humans versus animals, there are relatively few with children and largely focused on children who have issues with obesity, with only one recently published with childhood cancer survivors. But this study was really encouraging. So Don Mabbitt at the Hospital for Sick Kids in Toronto recently completed an exercise intervention program for childhood brain tumor survivors. This was a manualized program, so it really was specific in how they proceeded, that had 3 sessions per week for 12 weeks, and the sessions were each an hour and a half. The participants included brain tumor survivors who had received cranial radiation and were between 8 and 16 years of age. They had a multidisciplinary staff with a physical therapist and psychologist, and you can see the structure of the sessions there that included warm-ups, fitness games and aerobic training, organized sports, a cool down, and then time for snacks and rewards. So they are doing pre and post assessments for this study that include assessments of fitness and motor proficiency, cognitive performance, and neuroimaging. And these investigators found an improvement in reaction time, so how quickly children responded on attention measures, that corresponded to improvements in white matter. That's that myelin or insulation that allows for efficient communication I discussed early on. And this was based on a particular type of neuroimaging called diffusion tensor imaging, or DTI. They also observed increased hippocampal volume on MRI, and the hippocampus is a brain structure that's very important for memory, so that was encouraging. So when we think about physical exercise, the benefits are that we know there are physical benefits to the lungs, to the heart. They are relatively inexpensive and easy to implement. And there's no standardized, but the challenges are that there's no standardized dose. So we don't know which type of exercise is going to be most beneficial, how long you need to do it, and at what intensity. And there may be some physical or motivation limitations among childhood cancer survivors to sticking with an exercise program. So here is a listing of current trials that are enrolling participants. The first 4 are children still undergoing treatment. The last 3 are for children after completing therapy. I am not personally recruiting for these trials, but just sharing this information that may be of interest to some families. So in summary, the field has really been building momentum the last decade, but there are still many areas in need of investigation to make sure that all survivors have the best possible outcomes. And here are just a few thoughts on where we may be heading. So rather than working only with survivors who experience late effects, we're working to intervene earlier, so during cancer treatment, to see if we can avoid some cognitive issues. We're also looking to combine different intervention strategies such as medication with coaching or computer training and exercise to optimize our intervention impact. We're looking to increase our reach by offering interventions in the school setting, particularly for children in low resource areas. And we're using technologies such as genetics and neuroimaging to see if we can best identify those at risk for late effects, intervene early, and select interventions that best match a child or student to their particular need and the intervention that will be most effective. And we're looking to use potentially real-time neuroimaging where we have children or survivors in the scanner, the MRI, and we have them engaged in cognitive tasks and actually train them to use their brain in the most efficient way in real time. So I'm going to go ahead and stop here so that we have time for discussion and questions. Thank you.
Thank you, Dr. Conklin. You've given us a wealth of information, and we appreciate you sharing your expertise with us. I want to remind our participants, if you have questions, please feel free to go ahead and type those questions into the Q&A feature. And also to remind you that you will be receiving the slides and recording of this webinar following completion of the webinar. At least sometime this week, we'll be sending those to you. So you'll have that as as a resource. And I'll go to one of the first questions that we've received, Dr. Conklin. Someone is asking any questions on how to get a neuropsychological evaluation. We are in Western Washington. So where do we go to get a neuropsychological evaluation?
Yes, so neuropsychologists are located all throughout the country, and probably your primary care team will have the best resources within your geographical region, even if you were treated remotely. For example, we see families from all over the country at St. Jude, but can work with them to identify providers in their community. Most children's hospitals will have neuropsychologists on staff, but there's also neuropsychologists that can be in private practice in smaller communities. So that would be the best way, is to start with your medical team and try and get recommendations in your area. If individuals really do have difficulty, I'm happy to have their provider email me. I do have access to listservs and ways to look for providers in specific geographical regions.
And then we have a educational focused question. Do you feel like an IEP is better than a 504 plan?
So it really is going to depend on the particular student and their needs. And again, starting with the neuropsychological assessment is helpful because everything I've been presenting is really group data based on the research. But as you know, every child is different. So starting with that assessment, so you can see specifically what your child's strengths and weaknesses are and what sorts of services are recommended, including school services, will be an important first step. That said, if your child really just needs some accommodations and modifications, so that's the language they use for 504 plans, this includes things like extended time, access to teacher notes, preferential seating, doing every other problem, 2 sets of books, those sorts of things that are just sort of accommodating and modifying things to support them without actually changing their curriculum or the type of instruction and subject matter that they're learning in school, then a 504 plan may be sufficient and appropriate. Children who need extra assistance, that might include things like some pull-out time, where maybe they're working in a small group or one-on-one with a special educator to get, for example, extra assistance with reading or math, or if they need a related service like speech language therapy, occupational therapy, or physical therapy within the school, or to be considered for extended year services where they receive education throughout the summer. Those sorts of school services will require an IEP. So it will really depend on what the needs are for the particular student, and a neuropsychologist and the special educator at your school should be able to help you, guide you in either way. But those are the basic metrics. And one other point I just want to make is that only public schools are required to have individualized education programs. It's up to the discretion of private schools how much of that curriculum modification they will do. But private schools still are required under the ADA to provide 504 type accommodations and modifications. Similarly, colleges are also required to provide 504 type accommodations and modifications.
Thank you for that. Dr. Conklin, someone is asking how accessible are the computerized interventions to children that might have hearing or vision deficits?
Oh, that's a great question. The hearing deficits are probably easier to accommodate for computer-based programs. So the ones I'm most familiar with, like Cogmed and Lumosity, that we've done research with, you could do without, with complete hearing loss or accommodated hearing, because everything is presented and rewarded and explained visually to you. Children who have visual challenges may be more limited in these tasks because the computer interface does require some interaction with visual stimuli. What we do here at St. Jude when we're considering these sorts of interventions, either clinically or for research, is we actually put the child in front of the intervention on a tablet or a computer and have them just do a little trial to see how they can access it. So, for example, one of our biggest challenges are children who have had posterior fossa syndrome and are still recovering their motor skills and have difficulty with a mouse to work on a computer. So we'll actually put them in front of the program and watch how they interact to make sure that we wait until their motor skills have recovered enough for that program to not be frustrating for them.
We do have a question related to posterior fossa syndrome. So is there any specific research or findings related to this syndrome for cognitive and attention issues?
Yes, so posterior fossa syndrome is a really active area of research right now. People who are less familiar with that is, so posterior fossa syndrome is a syndrome that occurs shortly after a cerebellar or injury in the posterior fossa. So in children with brain tumors, this often occurs a few days after surgical resection if they require a really aggressive surgery of tumors sort of centrally located in the back of the brain in that cerebellar area. And what happens is that children typically come out of surgery and are similar to prior to surgery, but within a few days' time have a constellation of symptoms that emerge that include motor impairments, most notably ataxia, which is sort of real difficulty with smooth motor movements, speech changes, which can include complete mutism. And some people call this syndrome cerebellar mutism syndrome for that reason, or can just be significant changes in their ability to produce fluent speech. And then changes in behavior. And most often this is seen as just a type of irritability that is not common of that child, where they have sort of crying spells and decreased frustration that is not typical for them. So when we see those constellation of symptoms emerging shortly after surgery or cerebellar injury, we usually call it cerebellar mutism syndrome or posterior fossa syndrome. We do know that, and I should say there is now an International Posterior Fossa Society that started in Iceland and is bringing together experts yearly in this area to do research, including a number of us at St. Jude, to better define what posterior fossa syndrome is. It used to just be the clinician said yes or no, but now we understand there are some children with very mild posterior fossa syndrome and some with more significant. And those children who have more significant posterior fossa syndrome, for example, who take several weeks for their speech to return rather than a few days, have more risk for cognitive problems down the road. So we're trying to better define and diagnose posterior fossa syndrome. We've also now followed children out at least 5 years here at St. Jude, where we match children who experience posterior fossa syndrome with children who do not on all the other risk factors. So like their age at treatment and where their tumor was located and how much radiation they received. And we see that even when those acute problems resolve, which usually the speech and the motor and the irritability largely resolve in the first 6 months to a year after their surgery, we still see that they have more problems with attention and executive functioning 5 years out after their surgery. So we do know this is an acute risk factor as well as a longer risk factor. And we're trying to better understand why that is and why this occurs. And we're starting to gain some ideas from things like neuroimaging. So all that said, the same type of interventions I've reviewed would be of benefit, and we are using in children successfully who've had posterior fossa syndrome. But typically, as I mentioned with the one example of CogMed, we wait until sort of that acute rehabilitation phase is done. And during that time is really when the speech language pathologist, the physical therapist, and the occupational therapist are working to quickly recover a communication system and motor abilities. And then we come in with our typical cognitive interventions after that really initial acute recovery period.
Thank you for that great information. We have another question from someone who has another complicating issue along with the brain tumor, and that is autism. So how can we address children who have brain tumors and autism? There's a lot of know-how addressing autism, but not necessarily the brain tumor. Providers want to focus on one issue over the other. So how can we make sure that we get both issues covered?
That's a great question. It's a really hard one. It's quite rare that we see children with both diagnoses, although I do work with a few families of children with both autism and recovering from their brain tumors. Again, assessment is going to be really key because there's, just like with brain tumor survivors, there's a lot of variability in cognitive strengths and weaknesses. There's a lot of variability in autism in terms of needs, particularly in regards to language and social interaction. So getting a really good evaluation, which would probably also require someone with expertise in both areas who are very familiar with autism and cancer survivors. And then figure out sort of what are the greatest driving needs. Likely a number of the recommendations will be shared. So things like being in a classroom with decreased stimulation, fewer students, sort of visual schedules that are posted for the child to keep track of the day throughout, more smaller group instruction, more tailoring of academic lessons to that child. Those things are going to be in common for both individuals. Individuals on the autism spectrum, depending on what their symptoms look like, will also need support for things like social interaction and social communication that may require a different skill set than just a teacher working with a child who's a brain tumor survivor. So it sort of depends on the child. If the child has autism that is significantly impacting their communication and social skills, it's likely that being in a classroom that caters to the needs of children on the autism spectrum will be important, but then bringing in that extra expertise from individuals that work with cancer survivors in terms of the attention issues and the processing speed issues. If it's a child with higher functioning autism, for whom those symptoms largely aren't interfering with their academic instruction, then it may be more appropriate to be in the mainstream classroom with the type of interventions that are more specific for brain tumor survivors.
Thank you for that. We have a more generalized question now. With the gap brain tumor survivors experience as they learn slower than their peers, do they eventually catch up as they become adults and learn better how to compensate for their challenges?
It's a great question. It's one we continue to learn about. I can say that most of our research with brain tumor survivors until recently has only extended sort of out to the first 5 years. But as survival rates increase and we have more and more survivors who are adults, we are following individuals further out in time. So in terms of cognitive late effects, usually we see sort of some acute effects around the time of treatment that are more related to sort of sleepiness and arousal and attention issues. And then we sort of see at 2 to 3 years the most notable cognitive problems, which are sort of those attention, memory, and processing speed I talked about. And then we sort of see that asymptoting or sort of leveling off at about 5 years out from treatment. So at that point, you're sort of in a steady state and we kind of really know what we're working with and what skills we need to train on and where we need to have support services. That said, typically we don't say that children will catch up, because in order to catch up, that means that the child needs to be learning faster than their healthy peers who have not had any sort of brain tumor or medical intervention. And we just know that's not realistic for healthy children, let alone children who are struggling with some of the deficits they've acquired with their brain tumor and their treatment. So catching up isn't something we usually talk about or see, but we most definitely see children that with interventions, such as some of the ones I reviewed, who do improve their own skills relative to themselves, and also with interventions and supports become more successful at school and have less frustration over time.
We have so many great questions coming in. I wish we had much longer, but we'll be able to take a few more. One of the questions is really based on social issues. Someone who has a medulloblastoma survivor who's 22 years old now and has trouble making friends and has had this issue since diagnosis. Any recommendations for programs that might help with socialization?
I can give some initial thoughts. I have to say it's a little bit outside of my primary area of expertise. I certainly work with survivors who do have social challenges. And we are doing research here to better understand where those challenges come from. So for example, is it having had a very different life experience. So we often hear survivors talk about how it's hard to relate to their peers because, they talk about having a bad hair day. Well, maybe they didn't have hair for 2 years. It's sort of hard to empathize with those sorts of young adult types of issues. We also have individuals who have lost sort of periods of time where you critically are developing social skills. So particularly sort of like preschool, kindergarten, first grade, where you're really learning to turn take and to share and to take other children's perspective on situations. We also know that some of the cognitive challenges that our survivors experience, so for example, difficulty with attention, may cause some of the social problems. So maybe you're more impulsive and you kind of blurt out things that otherwise you might not have said and could be hurtful to someone if you had sort of stopped and thought through it. Or maybe you have trouble paying attention to non-social cues like facial expressions. So there's lots of different reasons why individuals may have social difficulties. So again, an assessment can really help tease apart that. But then there are social skills groups that people are working on, where you bring survivors together or their caregivers and sort of talk about some of the things that can be put in place. So for example, we call them social scripts. They're sort of coming up with common social scenarios like meeting someone for the first time or going to a party where you don't know a lot of people or going to the store and interacting with the store clerk. And you sort of prepare yourself for what that interaction would look like and actually have a script of how you might interact. And then you role play with either a therapist or an adult or a peer so that you gain more confidence and experience with those interactions. So there are social skills groups. There are education for survivors. A lot of these are in person. Some of them are starting to emerge online and be done remote, even with avatars, for example, where survivors can interact with other survivors in virtual reality space. The research for them is still emerging to understand which are going to work best. But probably the most pragmatic advice I can offer is really just trying to provide scaffolding or support for that young adult. So figure out what are their most enjoyed activities, whether that's painting or music or attending church or riding horses or whatever it is that brings them the most joy and has the least sort of to do with academics, to sort of have a break from things that might be more cognitively challenging, and to make sure that you're regularly setting up opportunities for them to do those activities that have peers or children who are a little bit younger present, so that it's a non-threatening environment that they enjoy that can facilitate those sorts of interactions.
Those are wonderful suggestions. Thank you. Has your research looked at the difference in cognitive skills between cancerous and non-cancerous tumors?
I might need some clarification. I assume we're talking all about brain tumors. Is that a correct assumption?
Yes.
Okay. I think that it will have less to do with whether the tumor is cancerous or not, and more to do with what sort of intervention is needed. So, for example, we work a lot with children who have craniopharyngioma, which is a brain tumor that is considered non-malignant or non-cancerous. But because of where it's located, which is near key vision structures and key endocrine structures, it often cannot be fully surgically removed, and they often require radiation therapy as part of their treatment. And so for those reasons, those children would be at similar risk for cognitive effects because of the mass effect of the tumor, the risk for that hydrocephalus or that buildup of fluid, and the radiation treatment. But we might have other groups. So for example, children with something called neurofibromatosis, who can have benign tumors in other areas, that we know that they're prone to those brain tumors. They're usually followed with MRIs to make sure that they're not having issues in where they're impacting the brain or causing hydrocephalus. And if that's the case, they may not need any intervention and therefore may be at less risk for having cognitive problems.
Thank you. We have time for one more question. Would you comment on anxiety and post-traumatic stress, post-treatment recovery in young adults? Wondering if these symptoms are neurological dysfunction, or should they be treated psychologically or pharmacologically?
Another really good and tough question. People are keeping me on my toes today. So, what we know about sort of mental health amongst our survivors, we know that survivors are not at increased risk for what we call sort of externalizing behavior problems. So, those are things like conduct problems and acting out kinds of things. We do not see an elevated rate of those problems amongst brain tumor survivors. We do see an elevated risk of what we call internalizing mental health issues, which are things like anxiety and depression in our survivors, and social withdrawal. And so those are the areas we're really trying to monitor closely in our survivors and make sure we intervene. In those situations, the same medications can be of benefit. So evaluation by a psychiatrist is appropriate, and they may recommend what we call anxiolytics. So those are anxiety drugs like Xanax, for example, or antidepressants, or like selective serotonin reuptake inhibitors, SSRIs like Prozac, for example. And those medications are safe and appropriate if there's anxiety or depression after treatment for childhood cancer. Actually, the rate of PTSD is an area of research debate. The chair of my department, Sean Phipps, is an expert in this area and has conducted some really eloquent studies to show that the rate of PTSD is actually not higher among childhood cancer survivors. And often when children meet criteria for PTSD, the trauma that they're reporting is actually not their cancer treatment, but some other trauma in their life. So that in one vein is very encouraging that our children seem to have great resiliency and seem not to be at increased risk for PTSD, and actually report a lot of what we call post-traumatic growth or benefit finding, where there's positive things they've gained from this experience in terms of learning what to value in their life and learning where their strengths are. But there are some children who could develop PTSD related to their treatment. Again, not at a higher rate than the general population, and sometimes not even related to the trauma of their cancer diagnosis or treatment. And those children should also be evaluated psychiatrically. And the same sorts of treatments would be appropriate, which would include things like exposure and response prevention, so that, and systematic desensitization. So those are things like learning what sort of triggers lead to these anxiety reactions. So is it being in a hospital, or is it seeing an injection or an IV tubing or something? And then learning relaxation strategies and other ways to pair with those events to decrease the likelihood that those triggers will cause symptoms of PTSD. So I guess the short answer is that our children tend to be very resilient, tend not to be at an elevated rate and risk for these problems, with anxiety and depression being the most common. PTSD can happen. You need to make sure it is actually related to their cancer experience. And in the cases where children meet criteria for anxiety, depression, or PTSD, the same source of treatments will be appropriate in terms of medication and therapy approaches.
Thank you. We have reached the end of our time together, so I will ask Dr. Conklin to stop sharing your slide deck, and we have 2 slides that the PBTF will now share as we sign off. I want to thank Dr. Conklin for her time today and for sharing her expertise and experience with us. This has been terrific. I also want to thank you, our attendees, for your engagement with the topic area, your participation, your thoughtful questions. The PBTF is here to help you no matter where you are in your journey. Please reach out to us for support at the contact information on this slide. We'll be sending you the link to the recording, and as I mentioned before, we'll also be sending you the slides at the email that you registered with. We have several resources to help you with your educational and survivorship needs during these challenging times. Our survivorship resource guidebook contains extensive sections on the educational system and late effects of treatment. Dr. Conklin was one of the contributors to this resource. It's downloadable on our website at the link listed here. So please take a look at that. We have a peer-to-peer mentoring program that matches trained parents and survivor mentors with others facing educational challenges, survivorship challenges. And our website also hosts our animated award-winning Imaginary Friends Society films, which are more for younger children, but explain a wide range of cancer topics in a way that kids can understand. And finally, thank you again for attending today, for your attention, for the engaging conversation. Please reach out to our family support team at the PBTF if there's anything we can do to help. Thank you.